Welcome to Beyond the Balance Sheet, the podcast that helps advisors, clinical professionals, and affluent families understand the complexities of issues related to our mental, physical, and emotional well-being. Our co-hosts, Arden O'Connor and Diana Clark, will interview a series of guests on a range of topics, providing informative content and practical tools for professionals and families to consider. Here are your hosts, Arden and Diana.
Hi, and welcome to an episode of Beyond the Balance Sheet podcast. Today, we're going to talk about physician wellness with Dr. Greg Skipper. Dr. Skipper has had an illustrious career, not to say that he's old or anything, but he has been instrumental in developing some of the standards that physicians use for physician substance use recovery programming, as well as an innovator in the ETG development of accountability tools, which measures biomarkers in the blood. So, welcome, Dr. Skipper. Thank you for joining us today.
My pleasure.
Did I mess up your introduction at all? Tell me.
Not too bad. Not too bad. Only thing is I am old.
Well, I don't like to use illustrious career with somebody who is not. So we will we'll talk about that. So I want to talk about mental wellness, mental illness, substance use disorders among the physician population, because you have done this large study and you are in the know, so to speak, of what is the propensity for medical professionals to have substance use disorders? What are you seeing?
Okay. So, that question's been kicked around for a long time. And I think the balance of opinion now, based on pretty good studies, is that the incidence of and prevalence of addiction among physicians is the same as the general population. So every group that's been looked at has pretty much been the same. It's pretty high. It's around 10 to 15% lifetime prevalence. So that means that in any group, whether it's lawyers or truck drivers or doctors, in general, that's about the rate of addiction, 10 to 15%.
Mm-hmm. Well, and that is significant. That's a significant percentage of our population, right?
So we all know that addiction's prevalent. It's a scourge, and it's it's a thing that's plagued our country for decades, and looks like it's going to continue, unfortunately. So every family almost has to confront this and deal with it, and it's not a illness or disorder that that any group is immune from. It tends to be quite equal among different professions.
Absolutely. Let me ask a question. I want to interrupt you for just 1 second. So if 10 to 15% of physicians struggle, just like the rest of our population, with substance use disorders, do they receive treatment at the same percentages, do we think?
The general population, the rate of people getting treatment is pretty low.
Really low.
Really low, 5% or so. With physicians, I think it's a much higher rate because they're held accountable, and they tend to show up. And once they show up, they need to get treatment in order to keep working, and they really value their work, so they cooperate and they get treatment and they get long-term monitoring, and their outcomes are really super good. So,
the best in the substance use world, when I model programming, it is based on the physician's model because the incidence of sustained recovery is higher than almost any other population. Is that true?
It's true. Yeah. And I think the reason for that largely is monitoring, long-term monitoring. So identifying that there's a problem and then getting people help and getting people in monitoring. So, for a long time, people looked at the great outcomes among physicians and they said, well, it's just because they're doctors. They have more going
Mm-mm.
for them or something. But
Mm-mm.
there have been a couple of large studies. One out of Hawaii, it was called Hope Probation, the Hope Probation Study, where they looked at felons that were on probation, and they were required. The requirement was that they had to maintain absolute, abstinence from alcohol and drugs, and if they didn't, then they would go back to jail. So this judge named Judge Alm, ALM, created this program. Prior to that, people were released, and they didn't have a defined result. They were told to stay sober, don't drink or use, and they were drug tested, but they didn't know how many times they would test positive before their probation would be revoked. So with this new program, they said, well, you have to stay abstinent totally. And that's what we do with doctors. We say you have to stay abstinent, totally abstinent. Any one positive test, and you're going to be pulled off work and have to do other things. So with the prisoners in Hope Probation, that was a change, and it was resisted, by the way, and because probation officers thought that the court would be inundated. Everybody's going to relapse a lot. But what happened is the relapse rates went down. So if we if we hold the standard that people have to stay abstinent, and we have monitoring and consequences, they don't even have to be that severe, but if there's consequences, it helps outcomes. And so that's what we've done with doctors. We've, they get identified because they're held to a high standard. Nurses smell alcohol in their breath, or they get picked up because of diverting drugs or whatever. And then they get referred for evaluation, for diagnosis, be sure what the problems are, whether it's more than one problem, depression or bipolar, in addition to addiction. So they get a thorough evaluation, and then they get sent to appropriate treatment. And then the most important thing is they then get long-term monitoring with consequences. So I've encouraged that in all my patients. That model can be used for everybody, almost. There are some few people that have lost so much they don't have anything else to lose. So there's hard to give them consequences except maybe jail. But when in a lot of families, for example, if a child is having trouble with addiction, the parents have a real hard time deciding what limits to set. But if working with somebody like you guys, I know this is what you do, is you work with people to help them decide how to deal with these things. If that's done properly and a contract is developed, the person, can't keep their car, or they can't be, their gym membership is dependent on their staying sober or whatever, and they're in good monitoring, the outcomes are much better, like they are with doctors.
So when you say monitored for a length of time, how long is it now? I know that
as long as
period of
possible.
monitoring has grown over the years.
Well,
to the
it's as long as possible. Yeah, it's a lifelong risk of illness. So the balancing point is, if the monitoring is known to be too long, then people resist being identified. In other words, like for the physicians, they figure out, if I come forward or if I get identified, or the program is identified as requiring 5 years or 7 years or whatever, that will sway whether they will accept help or not. So we don't want to say lifetime, because people go, oh no, I don't want to be in that program. But lifetime would actually be best, because the illness is lifelong, and the frequency and intensity of monitoring can be reduced. So anyway, the balance point for most is around 3 to 5, even 7 years in some programs, but some people end up in lifetime monitoring because they do better in monitoring, and they relapse when it stops, and so we just keep it going.
I mean, that makes sense. It is a chronic disorder, so we would look at, if you're looking at monitoring as a helpful tool and not just as a lever that spells bad behavior, then you don't have to look at it that way.
Yeah, it's setting up contingencies. You can even give positive reinforcement. So, if you stay sober, then you get to keep your gym membership and your BMW, or you get to practice medicine and be on these committees to help other doctors. Doctors like to do that. So there's some real positives for staying sober, and then there's negatives for not staying sober. So if those things are clearly defined and they're held in place, in other words, if there's adherence to that, then it really works.
In addition to accountability, though, there's got to be some other supportive tools that are coming along with that, right? We're not just monitoring. What kinds of things do you advocate in terms of support elements for physicians?
Okay, so I think that needs to be determined individually. So that's where a thorough evaluation comes into play to determine what kind of problems has this person had. Is it related to family issues, conflict in the marriage? Is it related to co-occurring psychiatric disorders? Is it, other overwork, things like that? So it depends on the nature of the problem. So an evaluation should determine that, and then treatment should be focused on that, and then long-term care would also be focused on that. So if, let's say there's been, let's say there's bipolar disorder, then you would want the person to have to commit to stay with a psychiatrist and take their meds and work with somebody and accept that they have that and that they need to cooperate and so forth. So so whatever else they need needs to be in place. One thing I wanted to talk about today is, what are the barriers to getting a program like this going, either in a in a state or a community or a family even? Like what prevents people from wanting to do this? And I think a lot of it is stigma. Number one, people don't want to have this illness. It's seen as a real bad thing, bad behavior, shaming. And nobody wants to have any illness, but mental illness, and particularly substance use disorders, have more stigma. So people resist the diagnosis. But beyond that, there's bigger institutional issues that can prevent a program from being put in place. And what are those barriers? I think one is media. Media is always looking for scandals, and with professionals like doctors and judges and lawyers and even wealthy folks or politicians or whoever, the media is looking for problems, and so people may not want to set up a program like this because identifying the problem may lead to media attention and shame and scandal and all that. So media is a negative influence on making this happen. Another, in the case of doctors, and maybe in a lot of other professions, another systemic barrier is these groups that um, want to support public policy and like Ralph Nader type groups that make their living off of saying, doctors are dangerous. We need more punishment. We need more rigid systems. And that sets up a dynamic that makes it more difficult for people to want to come forward. So these consumer advocacy groups, which are really prevalent in California, by the way, in other words, people are making a living off of advertising that this doctor had a drug problem and so forth. And they think, well, then the medical board or the authorities need to get more involved. We need to get the police involved. We need to hunt these doctors down. And they make a big deal out of it because they want to generate more revenue for their advocacy group. And what that does is it stifles appropriate management because nobody wants to come forward when there's that kind of an atmosphere. Plaintiffs' lawyers are also a barrier. So, we know that people get sued. And the plaintiffs in California, the Trial Lawyers Association has supported the consumer advocacy groups to make a fuss about this and pressure the medical board to be more harsh. So there's a number of things going on, and that's particularly focused on physicians and other health professionals, but it kind of relates to anybody. If we're going to have a program to manage these things, all this kind of relates. And then the final thing is like the regulatory boards, like the medical boards in the country. Every state has a medical board and a pharmacy board and a nursing board. All these boards, their task is to make sure that the public is protected, that the practitioners are safe. And because of sunset laws and things like that, they have to justify their existence. So the more cases they can come up with that they've identified and punished in a way, they get more funding. So that's a barrier to having a supportive program. So the ideal thing, I think, is to have early identification in a supportive atmosphere where people get a proper evaluation and then appropriate treatment and appropriate long-term monitoring. And that's the safest thing. It works. It's been proven in programs like Hope Probation. And the other one is called 24/7, which is a DUI program that I could describe if you want. But it's proven, and there's other studies too, contingency management studies, that have proven that if you set up the right kind of system, addiction is treatable and the success rate is good or better than any other chronic illness. If you don't mind, I'd say a little more about contingency management. That's an interesting thing.
Yeah, okay. Talk to me about it.
It's the same kind of thing that I've been talking about, but it sort of approaches it a little more from a conditioning point of view or something, like from experimental psychology or something. So what they've done is they've had programs where, for example, teenagers that have problems with marijuana, they've set it up so that every negative drug test, when negative meaning they don't have, clean drug test, when they have a clean test, they get $5 into a bank account or whatever amount, $10, and that accumulates for every negative drug test. And if they have a positive drug test, it goes back to zero. And periodically they get to take half of the money out or whatever. So the different schemes like that. And if you do that with a group of teens and then the other group, you don't do that, but you do everything else the same with counseling and so forth. The ones with contingency management in place do a lot better. So just a little bit of positive reinforcement with a little bit of negative if they have trouble. And it's not, you don't shame them. You're just saying, if you can stay sober, you're going to get some reward for that. Now, those programs have been criticized because people say, well, why should we reward an addict for being healthy, for not using? Well, the reason is because it works, so, and I think families should think about that. Like what are the limits that can be set, and how to set up a system, to do supportive intervention, get appropriate care, and then set up a system for long-term monitoring that's got the right stuff in place. And it's not like we're going to excommunicate you from the family if you ever use again. See, because that's too much. People won't even want to do that. Parents are unwilling to kick their kids out on the street because they could die. And then, how's that going to feel? That's horrible.
I also am not a huge fan, and let me ask you this, of using emotional affection as leverage. It's one thing to say, I'll take away your car. It's another thing entirely to say, and I'll stop talking to you.
Oh, yeah. I wouldn't do that either. I think they need to figure out what is it. There's things, like, allowance, there's things like college or
privileges,
use of a car. Yeah, privileges, having a gym membership. And you might say, well, what difference could a gym membership make? It doesn't have to be a lot, just any, each case has to be studied and figured out. But I can cite numerous examples. Because I've worked in this physician model and I'm trying to get everybody to use it. By the way, there's resistance to this also from counselors. A lot of alcohol and drug counselors, when I've talked to them about this, they're like, we don't want to put people in monitoring. We want people to be in recovery. We want to see, a change spiritually, that they really turn their life around. Well, everybody would like that. But that's not inconsistent with monitoring. So I've tried to convince counselors, alcohol and drug counselors, to accept the idea that monitoring can be useful. And when they do, they see it. It is useful. So we want them to be in recovery. We want them to change their life and change their, their attitude about all this. But having accountability in place is not a barrier to that. So an example would be, like, I had a 24-year-old son of a doctor, and his mother was a lawyer. And he had been in treatment 6 times since he was 16. And so when they came into treatment with us, the parents came with them to admit him to the treatment program, and they were discouraged. 6 times in treatment. This is not working, So I said to them, would you be willing to develop a contract at the end of this treatment? And we worked together, and we decided on some of the things I've mentioned. He got to keep his car. He got to have gym membership, and they paid for him to have a modest apartment in this area, which was good because then he could stay with his aftercare. And he has done great, and for years now. So that really is an example of that really working.
Anything that works, because the media, the culture likes to say substance use disorders are not treatable, that they are shameful, that they are lost causes. I know differently, you know differently, and it's good to hear it.
Tom McClellan is a researcher who's written a lot about comparing addiction to other chronic illnesses, like, things like diabetes or hypertension or asthma or things, any chronic illness can recur. And what he's determined is that addiction is as treatable as any of those other things. So, asthma can recur, but if you set up the proper, if the person's educated and they've got the proper incentives, then you can intervene early and get people back on track. And same thing with addiction.
That's great to hear. Thank you, Dr. Skipper. This has been a wonderful conversation. I appreciate you joining us at Beyond the Balance Sheet podcast.
Thank you.
And to our listeners, thank you for joining us today at Beyond the Balance Sheet podcast. And if you found this episode or any episode interesting, please like us on your platform of choice.
Thank you for listening to Beyond the Balance Sheet, a podcast designed to help advisors, clinical professionals, and affluent families solve some of their biggest medical, psychiatric, and emotional challenges. Visit beyondthebalancesheet.com to read more about our guests and resources, and sign up for our newsletter.